Guys, the AUA has released the new genitourinary syndromes of menopause right here, AUA SUFU OGS guidelines, and I'm going to talk you through it right now. First up, scene number 2, everyone with symptoms or signs of genitourinary syndrome of menopause should have a GU examination. That means that your doctor should be looking at your vulva and your vaginal tissues to assess if you have signs and symptoms of GSM. So what does it mean when you get a physical exam? One is that the doctor should be checking your clitoris, your prepuce, your labia, so your outer lips will get smaller, your labia minora, your inner lips will resorb, meaning they will get significantly smaller and go inward. And your pH, your vaginal pH, which is so simple to check, it's just a little swab checking on a pH paper, will be greater than 5. Here, down here, you can see the symptoms and signs of the genitourinary syndrome of menopause. So if based on your history and your physical examination, you are having signs and symptoms, dryness, discomfort, pain with sex, you should be offered low-dose vaginal estrogen or alternatively vaginal DHEA or ospemifene. If you also have symptoms of overactive bladder, vaginal estrogen can help as well. And so talk to your doctor about that. Also, if you're having recurrent UTIs, vaginal estrogen is so successful in reducing the recurrence of UTIs. We just published data at the AUA by Dr. Elise D showing that vaginal estrogen reduced the risk of hospitalizations and sepsis and UTIs significantly. The other thing that's noted in the guidelines that you all need to know is if you're on hormone replacement therapy, orally or through a patch or a gel, that's not going to be enough. You can see here that you might not get adequate relief of your symptoms with just systemic estrogen alone. And based on review of the data, they found that using CO2 laser, YAG lasers, or radio frequency treatment of the vagina does not offer treatment success in people who are having symptoms for genitourinary syndrome of menopause. So you can see here they looked at 11 clinical trials and they found that in energy-based interventions, the different types of lasers and radio frequency had really small studies with short follow-up, only up to 3 months. And so the certainty of evidence is very low based on this. And in terms of when they compared CO2 laser with a sham laser, they saw no difference in any of the symptoms that were concerning. So this is an option for people who may be unable to take vaginal estrogen or other options like ospemifene or vaginal DHEA, or they are not getting relief with vaginal moisturizers or lubricants, but the data is limited. The use of vaginal estrogen does not increase the risk of primary breast cancer or recurrence of breast cancer in women who have a personal history of breast cancer. Here you can see it does not have a risk of breast cancer, stroke, endometrial cancer, colorectal cancer, or blood clot. And sometimes systemic estrogen may increase, although it's very uncommon. When it does, it's usually briefly, lasts less than 12 weeks, and then back to menopausal estrogen.